Now one.
All right. Well, thank you to the UDA for inviting me to give this lecture. And my name is Dan Thunell. For those of you who don't know me, I'm a periodontist here in Salt Lake. I practice in Holiday and went to BYU. I apologize to all of you U fans, but I am a Cougar. And then went to University of Pittsburgh for dental school and the University of Iowa for my perio residency. Moved back to Holiday. We've been here about 12 years now. I teach part-time up at the dental school at the U. So I guess you could say I have some dual allegiance there. I've actually been part of the U longer than I was part of the Y. But all the same, I love the balance that gives to my career. I really enjoy the clinical aspect of things, and I really enjoy being able to share that with students as well. It's been very rewarding. And in the process, I've learned a lot as well. It's been very educational for me. So today we're going to talk about soft tissue grafting. And I kind of have 3 or 4 main goals for this lecture today. First is to just review causes of recession. Second, to understand indications and contraindications for treating recession. To look at some different techniques, different materials, and kind of gain an understanding of how they work and what can be achieved with soft tissue grafting. So as much as we want to make things look pretty, and soft tissue grafting is often looked at as a cosmetic procedure, there's much more to it. And so I like to think more about how can I restore function and how can I restore stability. We have lots of opportunities to do things to make them look pretty, but the work that we do, we want it to stand the test of time. All of us do. And so I want to focus my remarks today on primarily function and stability. Now, I am a clinician, and I promise not to bore you with a lot of wordy slides, but I do think that there's some important things that we need to address or bring up in our discussion of soft tissue grafting to understand some of the clinical scenarios that I'll show later on in my presentation. Gerald Bowers is one of the great minds, one of the great periodontists in our history, and is well known for many studies that he's done. In 1963, he specifically did some research on the width of attached gingiva. So we have keratinized gingiva, and within that keratinized gingiva, we have attached gingiva. And he was looking at the changes in the width of attached gingiva from deciduous to permanent dentition, and their study found that increased over time. And he also came to the conclusion that optimal oral health can be maintained with only 1 millimeter of that attached gingiva. In 1976, another study was done, and they found that the width of attached gingiva increased as age increased. And that this was interesting, the location of the mucogingival junction does not change in relation to the inferior border of the mandible with age. And so that would make sense, as we know that teeth move in an occlusal direction over time. And so if that width of attached gingiva is increasing, then the mucogingival junction most likely is remaining in the same relationship to the inferior border of the mandible. Now in 1986, Tenenbaum did a study and found that the width of attached gingiva did not increase from deciduous to permanent dentition. This went a little against the grain, but did find that it increased over time in permanent dentition. And in 93, Andelin and Sobacki did a study that showed that it did increase both in deciduous and permanent dentitions. And so the bottom line of all of this is to show that attached gingiva does increase over time. And according to Bowers, there is a minimum necessary amount of keratinized gingiva, or excuse me, of attached gingiva. Now, we'll talk more about that later in the lecture, but I might challenge that just a little bit. So let's look first at some different classifications of recession. In 2011, the system that I currently use for classifying recession was developed in 2011 by Francesco Cairo. And it's a very simple system, RT1, RT2, RT3. And so with RT1, we have buccal or lingual recession and no loss of interproximal attachment. So here's an image to demonstrate that. You can see some recession there on 25 and 26. However, we have kind of a nice knife-like papilla still coming up interdentally there. And now as we look at RT2, recession type 2, we have recession on the buccal, and we have a little bit of interproximal attachment loss, but it's less than what we have on the buccal. And then we have RT3, where our interproximal attachment loss is greater than the buccal or lingual attachment loss. So as we know, the CEJ moves in a coronal position as it moves interdentally. And so as you look between 24 and 25 here, we actually have more attachment loss interdentally than we do on the facial aspect of those teeth. Now, a system that maybe we're more familiar with, a more classic system, is the Miller classification, which came about in 1985. Class 1, 2, 3, and 4. And how does that relate to the Cairo classification? Well, they're very similar. Recession types 1 is the same as Miller classification 1 and 2. A recession type 3 is the same as Miller classification, or sorry, recession type 2 is the same as Miller classification 3, and recession type 3 is the same as Miller classification 4. So not a lot of differences, however, less importance placed on the location of the mucogingival junction with the newer classification system. If you start digging into this and doing a lot of research, you're going to find many, many different classification systems. And they look at things from the width of the teeth to the level of the interproximal attachment, to the position of the tooth and the arch, lots of different in occlusion, out of occlusion, lots of different parameters. And you can really get bogged down in picking this apart. But for a day in, day out clinical practice, you need something that's simple to use and easy to use. And this classification system, these classification systems, the Miller and the recession type or the Cairo classification systems, meet those needs. These pictures here really demonstrate the importance of looking at some of those other factors. And while it's nice to be able to quickly make a determination and make a classification, you have to appreciate the buccal lingual dimension of the tooth as well. And you look at this canine number 11 and then the image on the left, and you can see that it has a bit of a buccal prominence, if you will. And if you were to flap that gingiva back, you might find that there's a dehiscence, a bony dehiscence there that could be half the length of that root. And so it's important that we do some root modification in instances like this in order to make our grafting more successful. We want that buccal prominence to be in line with the adjacent teeth and as much in line with the alveolar housing as possible as well to be successful. Now let's talk for a minute about some different causes of gingival recession. First, we're going to look at tooth position. So as you look at this image here, and the question I would ask you is there gingival recession on tooth number 30? We see root exposure, the furcation is exposed, but is there true gingival recession? And my answer to this is no, there's not. What we have here is super eruption that has happened on 29 and 30 because the opposing teeth, 3 and 4, have been missing for some time. Tooth number 2, I know because I treated this patient, was in place for many years after 3 and 4 were removed, which allowed tooth 31 to stay in its position. Tooth number 2 has now subsequently been removed, and we see that the super eruption of 30 and 29 has led to root exposure. But the gingival margin on those two teeth, interestingly, is more coronal than the gingival margin on the adjacent teeth. Horizontal displacement. Here's a tooth of a patient who's about to undergo some orthodontic therapy. And the idea there is we want to move that tooth back into the alveolar housing. You can look at that image and see that the alveolar housing is extremely thin. You're probably not going to get bone to grow back around the buccal aspect or the facial aspect of this tooth, even with orthodontic treatment and moving that lingually. So tooth position is very important. Alterations from deciduous to permanent dentition. I'm going to spend a few minutes talking a little bit about eruption patterns. These are very important to understanding if recession is happening or not. We have active eruption and we have passive eruption. Active eruption is the tooth moving from its germinative position into a functional position. And passive eruption is tooth exposure that happens secondary to the apical migration of the gingival margin back to the cemento-enamel junction after a tooth has erupted into occlusion. So the tooth erupts, and then the gingiva, if you will, recedes back to the CEJ to expose the tooth in the oral cavity. Now there are alterations to these processes. We have altered passive eruption and we have altered active eruption. In altered passive eruption, when the tooth erupts into the mouth through the bone, the soft tissue does not retract back to the cemento-enamel junction. We often use the term short clinical crowns. When we have short clinical crowns, we have either altered passive or altered active eruption. A Panorex or a good series of radiographs can help you determine which you're looking at. In altered active eruption, as the tooth erupts into the oral cavity, it actually brings the bone with it. And so when you look at a radiograph, you look at a Panorex, you're going to see bone at the cemento-enamel junction or sometimes coronal to it. That's altered active eruption. So just the presence of soft tissue coronal to the cemento-enamel junction is not enough to tell you if you're dealing with altered passive or altered active eruption. You have to look at the radiographic evidence as well. And that's important because many times I get asked when patients come out of orthodontics, can we just do some laser therapy here or do a gingivectomy and put this tissue back where it belongs? And the answer is we need to look at the radiographs. We need to know if there's bone in the way of making that successful. So a few images here to show or demonstrate these principles. You look at the top image, we have tooth number 25, and the bottom, or 24, and the bottom image, we have tooth number 25. Both of these are displaying altered eruption patterns. And you, at first glance, might look at this and think we have gingival recession on tooth number 24 or 25. But at this point, we don't. Now, there could be other contributing factors other than just an altered eruption pattern. On tooth number 25 on that lower image, you could look at that closely and think, well, maybe there's a little bit of a frenum pull. And we'll address that in a minute. But essentially, we have some type of altered eruption pattern, not on these individual teeth, but on the teeth adjacent to them, where the soft tissue is covering the enamel. So we don't have any root exposure. You cannot detect a CEJ visually. You probably could with an instrument right there at the gingival margin on those two teeth. And so we get a lot of referrals in our office of young individuals, 8, 10, 12-year-old individuals that have a very similar presentation to this. And what I tell them is, you do not have any recession at this time. You might develop some recession in the future. Let's have you come back in a couple of years and we'll take a look at it. Or we'll have you follow up with your dentist and your hygienist. If they see some changes in the coming years, let's come back and address it at that time. We gain a few millimeters of recession in the coming years, we can always come back and get that easily covered with some soft tissue grafting. But by and large, you're not going to see anything run away from you. We look at this top image in 24 and 25. I'm not concerned about this patient going through orthodontics. They're in a mixed dentition right now. We know that there's going to be some change in the width of attached gingiva as they continue to age. Let's keep an eye on it. Let's watch what happens. We can always stop treatment and take care of it if we need to. And the same with this tooth number 10 and tooth number 24 for that matter on the lower image. So altered active eruption is your classic aesthetic crown lengthening case that we see. An individual comes out of orthodontics, or sometimes they reach their early 20s or early 30s and they finally decide they want to address their gummy smile. Here's a case. This was an interesting one. This patient in the upper left is where we started, had just finished orthodontics. This is how they came to us after having their brackets removed and wanting aesthetic crown lengthening to get that gingival margin back where it belongs. You can see in the image next to that, once we flapped back that tissue, we have bone at the CEJ or slightly coronal to it on all of these anterior maxillary teeth. We went ahead and did our crown lengthening procedure, resculpted that gingiva, and here it is healing at 2 weeks after the surgery. And we had a patient and a mother who were not very impressed now with the position of tooth number 10 specifically. They felt like it was not lined up with the adjacent teeth as well as it could be. And this individual ended up going back into orthodontics for a second round to do a little tweaking and straighten that out. And here's this Panorex. I know the image is really not easy to see probably as it's been copied and sent there, but you can appreciate that there is bone reaching up or extending to the CEJ or coronal to it in some areas there. All right. So that's alterations from deciduous to permanent dentition. Now let's look at tooth movement and orthodontics. So a few more slides here with some history. Study in 2001 looking at the change in the width of attached gingiva as they advanced mandibular incisors. And they found that there was no change. In 1981, Steiner found that there was significant recession with a labial movement of about 3 millimeters. Weinstrom in 87 said that the thickness of the marginal gingiva and lack of inflammation are determining factors for development of recession. And Renkema in 2015 confirmed that the proclination of mandibular incisors did not result in statistically significant recession. Now, they were moving these incisors or proclining them about 2 millimeters. So that previous study said 3 millimeters. And my interpretation of all of that data is that if you're going to move it more than, procline the incisors more than 3 millimeters, that's when you're going to start to get into concerns about gingival recession occurring during orthodontics. A case that we treated several years ago where we had a tooth number 24 that was labially inclined and the tooth number 23 that was lingually inclined. And so some work was done to expand so that 23 could be pulled out. We had an abundance of keratinized gingiva in that area, and so we thought we'll use some of that. We harvested a connective tissue graft as well, which you see in the top picture here. We then did a lateral pedicle flap or a sliding flap over that connective tissue graft, sutured that into place. There's the initial, and then there's the final after 23 was moved into place. And so a decent result and attachment gain on the facial of 24. Another case with a slightly different technique, including a frenectomy to release that frenum, which you can see creeping up there on the mesial of 25. Subgingival restorations. I'm not going to spend a lot of time on that, but needless to say, several studies have shown that a minimum of 2 millimeters of keratinized gingiva is necessary around a subgingival restoration or crown in order to prevent recession. And my experience says sometimes yes, sometimes no. Lack of keratinized gingiva. So is merely the lack of keratinized gingiva an indication for gingival grafting? This set of images here has taught me a lot about that and how to answer that question. If you look on the left-hand side, we have a canine that has erupted and is going to be moved orthodontically into position. Before that tooth was moved, a free gingival graft was placed around the margin of that tooth. And you can see that free gingival grafts were placed on the mandibular canines as well. Once that graft healed, that patient went into orthodontics and that tooth was extruded and moved into position. And if you look at that image on the right, what do you see? We have a free gingival graft, and then coronal to that free gingival graft, we have keratinized gingiva. Now, where did that keratinized gingiva come from? Well, it came from the extrusion of that tooth. As that tooth was moved into position, as this patient aged, that width naturally of attached gingiva increased. The sulcular epithelium rolls or folds out as that tooth is extruded, and a zone of keratinized gingiva is created. So my question is, was that free gingival graft necessary? And you'll have to answer that for yourselves. My answer to that question is no, it wasn't necessary. Another illustration of my point is a case that I did with uncovering an impacted canine, a very similar situation. We removed the alveolar mucosa that was overlying this canine, completed our treatment, sutured that alveolar mucosa in place. There is no keratinized gingiva on the edge of that flap. That tooth was then extruded and pulled into place through orthodontics. And if you look at the bottom image, you can see that a zone of keratinized and attached gingiva has been created. Now, where did that come from? Again, that came from a patient whose width of attached gingiva increased with age, and as that sulcular epithelium was rolled over as that tooth was extruded. So my conclusion from that is that uh, a zone of keratinized gingiva in the absence of recession is not necessary as long as good oral hygiene is maintained. All right. Now, in just last month's edition of JADA, or sorry, not JADA, of uh, J. Perio, excuse me, um, a best evidence consensus was published. And two main conclusions came out of that. First, that a thin and narrow gingiva tend to have more gingival recession compared with thick and wide gingiva. We would expect that. That makes sense. And interesting, currently there is no evidence to support the conversion of thin to thick gingival phenotypes in sites without gingival recession or a mucogingival deformity. And so you look at this image here, looking at tooth number 27, is a soft tissue graft necessary? And my answer and the consensus from this best evidence review is no. In the presence of optimal oral hygiene, good oral hygiene, a graft is absolutely not necessary. And you look at this individual, if they're 30 years old or whether they're 80 years old, we know that if they maintain good oral hygiene habits, that gingival margin is going to stay right where it is. Now, there is one situation where I am not willing to take chances, and that happens to be around implants. In 2006, Chung did a study looking at the absence of keratinized gingiva around specifically posterior implants and found that it was associated with higher plaque accumulation and gingival inflammation, but not with higher alveolar bone loss. I do not take chances on the absence of keratinized gingiva around dental implants. I have found as a general rule, there is always more inflammation, there is always more bleeding on probing around dental implants when there is not an adequate band, what I consider an adequate band of keratinized gingiva. And so I always recommend a good solid band of keratinized gingiva around a dental implant. I'd like to show just a couple of cases here. Look at this image. It's easy to start to critique the location of this implant or the placement of this implant. But my question to you is, if you knew that this implant had been in place for 25 years, would your critique be different? I imagine that when this implant was placed, it was lined up fairly well with the adjacent teeth. This implant has been in place for about 25 years. And over the years, the adjacent teeth have moved in an occlusal direction, which we know they do, and the implant did not. I think that maxillary anterior implants are some of the most challenging situations we are dealt with in implantology. We have many patients who come to us for second opinions on soft tissue grafting, specifically around implants in sites 7 and 10. Implants that were placed when they were teenagers, late teens, early 20s. Now they're in their late 20s, early 30s. We have 2-3 millimeters of implant or abutment exposed, and the patient wants to do something cosmetically. These are extremely challenging situations. The implant therapy alone is challenging, let alone the treatment of trying to cover that with some type of a soft tissue or even a hard tissue grafting procedure. But in this case, the patient was complaining she was constantly having irritation and inflammation of the gingival margin around this implant. The dentist wanted to do a new crown for her to cover up that silver abutment. She did not like that showing. And so we worked together. This is Dr. Craig Smith and I that worked together on this case. And this was the result we were able to give her. Definitely not ideal. We have a crown gingival margin that's still far superior to the adjacent teeth. However, we've created a healthy gingival margin, an adequate zone of keratinized gingiva, and Dr. Smith's done a great job of doing some cosmetic work there to cover up that exposed abutment on an old implant. Another case that I worked on where an implant was placed and subsequently a patient decided to go through some orthodontics, unbeknownst to the general dentist that they were working with. They completed the orthodontics, and lo and behold, we had loss of some facial bone on the implant in site number 7. They referred them to us, is there anything we can do to help improve the aesthetics of this zone, of this area? And so we did a vestibular access incision and some soft tissue grafting. And is that going to hold up forever? Certainly not. But can we get 10 years out of it, 20 years out of it? Probably. So just to review, lack of keratinized gingiva on natural teeth without recession, not an indication for recession. In my opinion, however, a lack of keratinized gingiva around a dental implant is an indication for gingival recession or for gingival grafting. Thin phenotype. In the perio world, we have updated a lot of our terminology in the last couple of years, and we have now replaced biotype with phenotype. So when you hear me say phenotype, you can imagine biotype. And in these situations with the thin phenotype, we have thin alveolar housing, thin soft tissue where you can almost see the roots through the soft tissue. These are, again, challenging cases, but we can change the phenotype around these teeth. We can create a thick phenotype with soft tissue grafting. And these can be very rewarding cases when you have multiple adjacent teeth with gingival recession. You can go in and graft those and provide them with a symmetrical gingival margin at the cemento-enamel junction. And just going back to that, I think it's important to note that soft tissue does reattach to previously exposed root surfaces. A very important concept to understand. We are not just laying tissue over these teeth. We are creating a connective tissue attachment to these teeth with soft tissue grafting. Frenum pull, another very common situation that we run into where a strong frenum causes recession on tooth 24 or 24 and 25. And we can go in and do soft tissue grafting, eliminate that frenum pull, and get these roots covered. Here's a case we treated with a very shallow vestibule, high frenum attachment, gingival recession on 24 and 25. And so we go in, we do our soft tissue grafting, we do a frenectomy, and here we are 3 or 4 weeks after all of that's completed. We have good root coverage, we have a good zone of keratinized and attached gingiva. We've deepened our vestibule and we've eliminated that frenum pull on those 2 teeth. And then finally, I'd like to address abrasion, erosion, and occlusion. We refer to these as NCCLs. And I know abrasion is not a term we use as much anymore, but we have a multifactorial condition here. It's not just overbrushing. In fact, I don't believe that brushing causes half as much recession as we've claimed it has in the past. I'm not convinced that aggressive brushing is a culprit. I am convinced that occlusion is a culprit in these NCCL lesions. I am convinced also that erosion plays a role in it too. And I know there have been some studies to show the effects of occlusion and erosion on the cervical area of teeth. And so what's our ideal treatment for these situations? Are we going to go pick out our rosewood or our light flesh pink composite? Is that the ideal way to address this? Are we considering the occlusion? Are we managing that? Are we having a discussion about acid reflux or diet that could be contributing to some erosion? I think all of those things are important, and not just putting a Band-Aid on it, but trying to find the cause, get it resolved, and then try to restore it to normal as best we can. Here's what I consider a beautiful case by Zucchelli, who's a great periodontist, a great surgeon, and working with his restorative partner, he had glass ionomer restoration placed on tooth number 6 here, and the occlusion was adjusted as well. I'll note that. And then the CEJ was established through the restorative work. He then subsequently came back with soft tissue graft, and you can see the final result there. Working hand in hand with his restorative partner, able to produce a really natural looking result, and probably the best long-term result when you consider the work that they did on the occlusion and other factors, contributing factors. Here's a class 5 restoration on a first molar, extending well beyond the furcation down the mesial root. Again, because of some NCCL that was present, we went in there and removed as much of that as we could. That was composite material, not glass ionomer material. So we're not going to get soft tissue attachment like we would to glass ionomer. Now I'll just step back and mention that the connective tissue attachment to glass ionomer it's considered a tissue-friendly material. However, you're not going to get as strong of an attachment as you would to dentin. So you're going to get some soft tissue attachment. It's a weak attachment. And so that's why managing the occlusion is really important in these cases. And then a soft tissue graft performed here in the result at 2 weeks. So looking at indications for soft tissue grafting, progressive recession, we notice recession happening over time, aesthetics, in an effort to prevent or treat root decay. If we have a high caries risk individual and we have recession, that's a good indication for soft tissue grafting. Lack of keratinized gingiva, I think I've hammered that enough. And sensitivity. So my conversation with my patients is that we are not going to eliminate sensitivity with a soft tissue graft. Now, truth is we might, but I try to paint it as don't come in here with the expectation that this is what we're going to do, because I can't always guarantee that the sensitivity is going to go away. I find that in about 50 to 60% of cases, we see sensitivity greatly diminished, sometimes eliminated. But we all know that even in the absence of recession, many individuals, many of our patients have tooth sensitivity still. Contraindications, deep probing depths. The one caveat to that is if that deep probing depth is on the facial surface or the direct lingual surface of a tooth which you're grafting, that can be addressed. You know, this is 2 birds with 1 stone situation. Here we are doing a gingival graft on 27. We've had a 6-7 millimeter probing depth, some bleeding on probing, and some recession. We flapped that area. Lo and behold, there's some calculus, maybe some food debris that was down there festering over time. We remove that, we do a soft tissue graft, and we're off and running. So deep probing depths, if it's interproximal, no. If we have mobility, class 1 mobility, I'll still graft some class 1 mobile teeth. Class 2, class 3 mobile teeth, you're not dealing with a recession issue. You've got more going on. You need to address that first and then consider addressing the recession. NCCLs, I would not consider an NCCL an absolute contraindication. However, there's some situations where it's just better not to graft. Root surface restoration, I put a question mark on that because it depends on the material that was used for the root restoration. As I mentioned before, glass ionomer is the most tissue-friendly material, and uh, and so if we know what that material is, and then we can get soft tissue to attach to it. We have many different sources for tissue grafting material, and I'm going to spend just a few minutes reviewing them, and I'll give my rationale for my preference. Autogenous tissue is considered the gold standard. That's what we see every study compared against, just about. Allograft, your classic alloderm or dermal tissue, is human tissue. We have xenographic tissue coming from animals, biologics, endogain, and guided tissue regeneration. So I don't know if this makes you smile the way it makes me smile, but when I see a nice piece of sashimi, I get really excited. You know, there's nothing to me more beautiful than a really nice, thick, wide connective tissue graft. Here's an example of an allograft. I would consider allografts the second best option to autogenous connective tissue. They can work well, and in some cases they work extremely well. I find in the long term, however, that the results are just a little subpar to a patient's own tissue. Here's a before and after, 2 weeks after grafting on teeth 5 and 6 with alloderm, or excuse me, this was dermis, Puros dermis. Again, same material, teeth 20 or 30 and 31. The result is good. I believe the result would be better using autogenous tissue. Sometimes autogenous tissue is not an option. Patient has a really shallow vaulted palate, and you just know that you're not going to be able to harvest the quality of tissue that you would want. In those situations, a allograft is a great alternative. Many times patients don't want to use their own tissue for anxiety reasons, and that's fine too. And I give them the option. I always tell patients, if you don't want to use your own tissue, that's fine with us. We have the allograft here, we can use it. I tell them I feel that the result will be better using your own tissue, but if you're not comfortable with that, we'll use the donor tissue. I find most patients are willing to use their own tissue, and I'll say too, and I'm going to go into this in a minute, I find that autogenous connective tissue is not as painful as we often make it out to be when we have conversations with patients. Most of our patients come back reporting that the donor site was not nearly as painful as their friends or their dentist had told them it would be. Xenograft, these are resorbable materials. I've never had any experience using them, and the research that I've studied on these show that they do resorb over time, and so I've shied away from them. Biologics like Emdogain, several studies by Mike McGuire down in Houston has shown really good success with Emdogain, especially in the increase of the width of attached gingiva. Again, it's a feel-good thing. I really prefer the appearance and the feel that I see with autogenous tissue. Even with an allograft over a biologic, I feel that the results are more long-lasting and more natural. And GTR, really popular back in the 90s with some Italian groups that were doing some research on GTR use in soft tissue grafting. It kind of fizzled out as newer techniques and materials came available. It's been kind of popularized again. There's some individuals that are pushing some specific techniques, vestibular approach techniques, using GTR membranes. However, we know these are resorbable membranes, and I've seen many of these cases 6 months, year after treatment, and I find that the results are not very impressive long term. So looking at different approaches and techniques, we have the classic free gingival graft. We call that affectionately the tire patch. Uh, I'm moving more and more away from using free gingival grafts. I haven't found too many situations where a free gingival graft would be better than a soft tissue graft, or excuse me, a connective tissue graft. With connective tissue grafts, we have many different techniques and approaches. I don't think anybody has a market on any one approach. People have tried to claim that they've invented this or that, but the truth is a lot of these techniques and approaches have been around for decades, and somebody will grab a hold of some obscure technique and try to patent it as their own idea, when in fact it's been around for a long time. Um, I'll talk just a minute about the final one listed there, the Vista technique. Oh, sorry, free gingival grafts. I'm not going to really dwell on free gingival grafts. Again, I'm not a big fan of them. But the Vista technique, or the vestibular incision subperiosteal tunnel access, is a really unique idea where you make a incision in the vestibular space, um, and you can insert your tissue through that space. And it's really impressive because it's a way to preserve the papilla and to plump up the papilla in some cases. This is Dr. Homazeda in California. I believe he's at UCLA, a great periodontist and a great um, uh, teacher. He was kind enough to share these with me, but this is a technique that he's been working on for many years, trying to perfect. And you see how he's bonded the suture with some composite to the teeth, so not really pretty for the first couple of weeks. But in an effort to really suspend that tissue, he's gone to some extreme lengths there to amplify that, or to augment that interproximal soft tissue. The tunnel technique, a very similar technique as in regards that you're not elevating the papilla. This is a technique that I really like and use. I tried to trademark it as the Thunell tunnel, but they didn't go for that when I approached them. But this is a similar technique where we preserve the papilla, we insert the tissue through the gingival sulcus, and we can get really nice results. Another case of tunnel technique. A combination here where we did a tunnel procedure in combination with a frenectomy. We see our donor site. Here we are 3 weeks after the surgery. We have complete coverage of those exposed root surfaces and very nice healing of the palate. Here's a before and after. So I'll talk for just a second about wound healing, and then we'll wrap this up. We have 3 phases of wound healing. We have plasmatic circulation that happens during the first 4 days. That then leads into vascular invasion, so we get those reanastomoses of those blood vessels through that soft tissue. And then we get our maturation, which happens from day 11 to day 42. So we really want to stabilize our soft tissue grafts for at least those first 11 days to allow us to get to that maturation stage and allow that connection to start happening. I talked earlier about pain associated with the donor site. This tends to be a conversation that we have a lot with our patients. They come in with this preconceived notion that there's going to be a lot of pain there. And by and large, when I make a point of it to interview them at that 2-week appointment or 3-week appointment and say, was it as bad as you expected? And by and large, our patients reply, no, it wasn't nearly as bad. And so I think if we follow just a few simple principles, we can really make this a much easier procedure and process for them. And that simple principle is digital pressure. Here's immediately after suturing the palate, after 1 minute of pressure, and after 2 minutes of pressure. And if we take the time to apply that pressure and create, you go back to that earlier slide, the plasmatic union or plasmatic, allow that plasmatic circulation to start, we've got to eliminate the blood clot between the two flaps of tissue. And so if we eliminate that blood clot, that plasmatic union is able to establish itself, and we see healing happen very rapidly in these cases. These are all photographs of palates at 2 weeks. Obviously, some heal a little better than others, but some people are healthier than others. But by and large, we're seeing most of our healing happening in the first couple of weeks, and patients really not complaining too much of pain. Severe recession. How much recession can we cover? I tell my patients, if you have 6 millimeters or less of recession, we anticipate being able to get that covered in your first appointment. Anything more than 6 millimeters of recession, we may need an extra appointment to get that tissue back where it belongs. So here you see 2 weeks after with this case, and yeah, we could have covered a little bit more. I showed this case earlier. This patient actually went through orthodontics and they were unable to move that tooth number 26 lingually. And so the orthodontist sent the patient and asked, can we just do a soft tissue graft and get that root covered where it is? And we were able to accomplish that for them. Last case that I want to end on, this patient had a free gingival graft. You can see just a hint of that graft sitting apical to tooth number 25. The tooth being treated obviously was number 26, but there was extensive recession on that tooth, and the individual that performed the graft told the patient that the root could not be covered. And so a free gingival graft was done. She came to us for a second opinion, and I told her, I think we can cover that root. I don't see any reason why we couldn't. However, the presence of that free gingival graft is going to complicate that. That's very thick, dense tissue and hard to move. But we did come back and do a connective tissue graft. We used that Thunell technique that I mentioned earlier. Here we are at 2 weeks, and here we are at 4 weeks. And so there's pros and cons to us, what we were able to do. We got the root covered. The patient was thrilled. However, I also moved that free gingival graft coronally, and now that's in more of a visible area. Obviously, on the lower anterior mandible, we're not as concerned about that showing when the patient smiles or talks. But it just illustrates that we can cover roots, and as I mentioned earlier, soft tissue does attach to those previously exposed roots. So with that, I'm going to wrap everything up. I want to thank the UDA for this opportunity to share these slides with you. And if you have any questions, please feel free to reach out to me. You've got my email there at the bottom, and I hope you all stay safe and have a great day. Thanks.